Anyway, so this is the original way people used to record ECGs with a galvanometer, and this gentleman here is Dr. Wilhelm Einthoven, who's the person that discovered all this stuff. And this is an actual reading of an ECG that they did, and this was actually the first ECG that was ever recorded. And you can see a P wave, a QRS, and a T wave. And everything we've learned from electrocardiography, it all came from this system. It's become refined a little bit, but ultimately, this is everything. So it's good to know the history of this stuff, because then it puts everything in perspective. Everybody still doing good with audio and visual?
Yes.
Now, I have no idea who's here, and I'm afraid to turn on my iPad to see who's here because I don't want to mess everything up. So, Deli, you're on again for picking victims. So, here's the first ECG we have of a 23-year-old female who's 24 hours after elective hip surgery. A nice general cardiology consult. So somebody who's on general cardiology should probably do this.
So I'm gonna, Paula, are you there?
She is here.
So she reluctantly said yes. Well, good. We'll go slow. We'll be nice and gentle. Promise.
I'll be brighter.
So starting off, it looks tachycardic, heart rate around 150. I sort of see maybe P waves, if this is a P wave.
They don't see that?
Oh, never mind. Yeah, I can see P waves.
Long
You can or cannot?
I can. I do.
Long RP.
You do see P waves. Whereabouts? You tell me where. Here, you see my pointer?
Yes. In lead 1, I can see P waves over here.
Lead 1?
Yeah.
Right here?
Say V1.
Yeah, V2, lead 2, you can see P waves over here, like this little, right there.
Yep.
Yep. Looks pretty regular, marching out.
So you see P waves in lead 2 and 3.
Yes.
You see them in lead V1 right there.
Yes.
V2.
Yeah.
So this is tachycardia that you said it's 150 beats a minute?
Yes.
So that means that 2 R waves are going to line up in between 2 big boxes, right? And here's an there's one that begins with a QRS. And does that line up with the QRS? That second box at 150 beats per minute?
Yeah, close enough.
Close? Not in ECGs, not close enough. Because it makes a difference, because if it's 150, our differential diagnosis changes a little bit, but it's a little slower than 150. It's like about 140 beats a minute. Okay, so anything else you want to comment about this ECG?
It's the QRS looks wide.
Okay.
On the precordial leads, like the ST, those T waves look peaked. V1, V2, V3, V4. Here's some ST depressions on V5, V6.
Okay. So do you think that this lady's having an infarct? Following her traumatic surgery?
I don't think so. Not in that well.
So why do you think she is or is not having an infarct?
I mean, the way that the ST are peaked over here, they don't look like tombstoning.
Okay. How about the morphology of the QRS complex? What do you think about that? Think that's normal, abnormal?
I mean, I don't think it's normal. It looks, widened.
Okay, and if it's widened, what do we call things when they're widened? Could this be ventricular tachycardia?
Well, in the setting of like seeing some P waves, Could just be like a bundle, like a left bundle branch.
A left bundle branch block. And what makes you think this is a left bundle branch block?
Well, you have the wide QRS.
So a QRS that's greater than 120 milliseconds, you got that, okay?
This negative here. Yeah.
So you have a rapid downstroke, V1, V2. So what happens in left bundle branch block, what happens to the activation of the ventricular septum? Is it normal or is it abnormal?
It's abnormal.
And what's the normal activation of the septum? From right to left or left to right?
Left to right.
Left to right. So if you see activation, a normal activation of the septum from left to right, what do you normally see in lead V5 and V6?
Negative.
Normally you see little septal Q waves, right? There's little tiny Q waves in V5 and V6. That's what it should show. And that's because the septum's being activated from the V5 and V6 are seeing things from the lateral wall. You're as far away from the septum as you can get, and you're looking straight on to the septum. So think of yourself on the other side of the Tampa Bay looking over at Tampa. So you're seeing all the events from afar. So if the septum's being activated left from right, therefore those you should see a little Q wave in V5 and V6 and sometimes in 1 and AVL. But you don't see those Q waves in V5 and V6 here. And that's what makes the diagnosis of a left bundle branch block. All right, a widened QRS, loss of normal septal activation. All right. Now, so can you make so if this is a left bundle branch block, could this be VT?
Okay.
Yeah. You can talk it out.
I mean, it could be.
Right. Well, then tell me why it isn't. I mean, you've already answered some of the question. You said there were P waves in front of every QRS, right?
Yes.
Does that rule out VT?
No.
Well, it depends. If there was a P wave with every QRS, it could still be VT, but that means that the ventricle would be activating first, and then the atrium would be activated second, right? So activation would be of the atrium from bottom to top. But you have upright P waves in lead 2 and 3, so you have normal P wave axis. So this P wave is being activated from top to bottom. So if this was VT with retrograde activation, that P wave would have to be negative. So you figured it out already that this isn't VT because there's a one-to-one PQRS relationship, and the P waves have upright morphology in 2 and 3. So therefore, this is not VT with retrograde activation. So you didn't know how smart you were. Just to put the words together. The other thing that says this isn't VT is because if you look at the initial forces here, the initial forces are very fast. The QS, the RS here is within 40 milliseconds, and that's not how VT is a muscle-to-muscle disease. And if you look at AVR is in a normal direction. So VT typically you're going to have an R wave, or you're going to have a very slow, a delayed S wave. So there's nothing here that looks like VT. And since we said the P wave axis was normal, going from top to bottom, this is probably sinus tachycardia with a left bundle branch block. But you still haven't answered my question, is this lady having an infarct? I mean, you're going to call the team in and say, oh, we have a STEMI here.
I mean, based on the EKG, is there any other information?
No, you're blind, deaf, and muted other than the ECG. It's like real world. So based on this, would you say, should I call the second-year fellow and say, man, I think this is an acute infarct? Can you make the diagnosis of an infarct with left bundle branch block?
It's a new left bundle branch.
Or
We
scar.
don't know if it's new or old. That's just it. This is the only ECG we have. It makes it difficult to make the diagnosis. There are some criteria that we can use, but so if you were doing a board examination and you had to like write your correct answers for this ECG, what would be the things that you would write? You would say this is sinus tachycardia. Yes. You agree? Okay. And we finally teased out left bundle branch block. What else would you say that's also here?
Discordant is the elevation.
Is this a normal P wave in V1? Negative? It's at least a box wide and a box deep, so that would be classified as left atrial enlargement or left atrial conduction delay for an exam. So because it's so negative there, you really can't tell how broad it is over here because you can't really see the beginning of the P wave. So this would be sinus tachycardia with a left atrial conduction delay. And how about the electrical axis here? Is it normal, abnormal?
Left axis.
Left axis. So is this a left anterior fascicular block?
120.
For the other left bundle.
I didn't hear if you said yes or no, because I know you
I
didn't
think
say.
so, yes.
Like, how can you have a left anterior fascicular block when you have left bundle branch block?
Part of the
Is that already wrong?
You can't. So you can't make those two diagnoses have to be exclusive. So you can, if you have a left bundle branch block, you can't have a left anterior fascicular block. So here you'd have to say, and left bundle branch block trumps. So therefore you'd read this as left bundle branch block with left axis deviation and some non-specific ST segment flattening. That's how you'd read this ECG on a board exam. See, that wasn't so hard. So now some questions. Q respiration of what is necessary to make the diagnosis of a complete left bundle branch block? You have 100 milliseconds, 110 milliseconds, 112 milliseconds, or 113 milliseconds. So which of those four is the most correct answer?
Is this for women or men?
Either. Doesn't matter. Left bundle branch block.
I thought Star's criteria
QTs
says,
are men and women, but everything else is unisex. So the standard definition of the left bundle branch block, complete left bundle branch block, is a QRS of 120 milliseconds or greater. So this could be a left bundle, this would be a left bundle, but this is the most accurate answer. If it's more than 100 milliseconds, and it has all the features of the left bundle branch block, you can call it an incomplete left bundle branch block. So greater than 100 for incomplete left bundle branch block, but 120 milliseconds for a complete left bundle branch block. So is left bundle branch block normally, is it seen in normal hearts? That's a true or false answer. You're a 50% chance of being right. True, yes or no?
False.
Right. False. Right. So it's typically when you see left bundle branch block, you have to think there's a reason for it, as opposed to a right bundle branch block. Typically you see left bundles with ischemic or non-ischemic cardiomyopathies. You can see with valvular heart disease, left ventricular hypertrophy, congenital heart disease. All those things can cause it. But so whenever you see left bundle branch block, you can't blow it off. You got to say, no, there's something that's doing this. It could be organic, and we should, they need a basic workup, basic cardiology workup. So non-voltage related changes are often associated with left ventricular hypertrophy. So all these things are included with left ventricular hypertrophy, except which? You get left atrial enlargement and abnormalities with LVH. Is that a thing that you could get with LVH?
Yes.
Yes. Okay. And how do we define left atrial enlargement? We talked about it.
Notched V wave milliseconds greater than 120 and lead to and negative deflection in V1 more than a millimeter.
and a box wide and a box deep.
Correct.
All right. Left axis deviation, do you see that in LVH?
Yes.
Yes.
You can go along with LVH, yeah.
No.
Can you get an IVCD with LV with left ventricular hypertrophy?
Yes.
Can you get a U wave? Prominent U waves with left ventricular hypertrophy.
I think so.
So if you think so, what causes U waves?
Yeah, I don't think we know.
There's several theories about what causes U waves, and the fact is that nobody knows for sure. But a lot of people feel it has to do with repolarization of Purkinje fibers, and other people feel it has to do with repolarization of in mid myocardial M cells. So one thing for certain is that they occur in normal hearts, but if you see an inverted U wave, that's always abnormal. That's never that there's some underlying pathology. So how about sinus arrhythmia? Does that go along with left ventricular hypertrophy?
Not really. Not really. No.
So how do you diagnose sinus arrhythmia? First of all, what is sinus arrhythmia? Who would like to tell me what sinus arrhythmia is?
Sinus rhythm with a variation of the P intervals more than 160 milliseconds or greater than 10% from baseline.
Somebody's been reading too many textbooks. You have too much time in your hand. You have to change your rotation.
What happens in secondary?
So, does the left bundle branch block interfere with the ECG diagnosis of which things? Which things does it interfere with the diagnosis of? Axis deviation. And for example, can you make the diagnosis of left anterior fascicular block when you have left bundle with left bundle branch block? You can't, right? So when you have left bundle branch block, certain things you can't make the diagnosis. Can you make the diagnosis of LVH when somebody has left bundle branch block?
Yeah.
I don't know.
It can, but the criteria become much less. They're sensitive, but they're very less specific. That's the problem. Can you make the diagnosis of right ventricular hypertrophy in the presence of left bundle branch block?
Probably yes.
Sure you can. Can you diagnose acute myocardial infarction in the presence of left bundle branch block?
Yep.
Right. And most people say with hesitation, kind of like pause on that one. But there are some criteria that we use. And if you look at what happens when somebody develops a bundle branch block, you tend to get discordant repolarization. So if you have a dominant, then it's normal to have a T wave going in the opposite direction. Likewise, if you have a negative QRS, normally the T wave goes in. And this is the normal discordance of a conduction disturbance. This is what you normally get. So somebody looked at this many years ago. Scarbozzi was her name, and she was the lead author on this article that looked at various criteria how to make the diagnosis of myocardial infarction in the presence of either left bundle branch block or a paced QRS rhythm. And there were three things that she looked at. The first was the regular concordant pattern. So if you had ST segment elevation going the same way or depression going the same way as the dominant QRS, then those things were quite specific. So if you had a millimeter of ST segment elevation or greater, or a millimeter of ST segment depression or greater, those things were very significant in making the diagnosis, and she ranked them and gave them points. And the other thing she looked at was an accentuation of the normal discordance that you get. So if you take a line and run it through your PR interval, then you divide your QRS down and up. If you have a deviation in an upward direction from the QRS to the J point of greater than 5 millimeters, that was felt to be significant. And when she looked at that, she found that, and she gave them various points, that this got 5 points, this got 3 points, and this got 2 points. And if you had a total score of equal to or greater than 3 points, you could make the diagnosis of acute myocardial infarction with this. And it was fairly specific, 80 to 90%, but unfortunately, it's not particularly sensitive. Only about 20% of people had that criteria. So if you see it, it's good, but unfortunately, not a lot of people are going to have it. Does anybody know of any other way to make the diagnosis of left bundle branch block in this setting? I take your silence as a no? Or is your silence that nobody can hear me?
No, I don't know.
Well, it turns out that, as ER doctors tend to do, they like to do these kind of ECG projects. There was this guy, Stephen Smith, did a modified Scarbozi's criteria, and basically he used the same thing. He used for the concordance, he used the same thing. But what he did a little differently, though, what he did is he looked at, instead of saying it has to be 5 millimeters, he developed a ratio. So he looked at the voltage below the QRS and the voltage above. This is the baseline PR interval. And if you measure this as voltage, you can see that down 3 millivolts, up 10 millivolts, that gives you a ratio of 0.3. And it doesn't matter if it's positive or negative. You're looking at the absolute ratio. And here it's down 10 and up 3. And he found that if there's an abnormal ratio of greater than 0.25, so if there's a deviation of 0.25 in ST segment elevation compared to the QRS amplitude, then that was actually made the criteria more sensitive without very much loss in specificity. So these are the modified Scarbozi criteria, but nobody really uses them all that much because they're too hard to remember. And that's the bottom line. I don't know why they don't program it into ECG machines, but because it's fairly easy to do. So the answer is you can make the diagnosis of acute myocardial infarction in the setting of left bundle branch block or pace rhythm using these kinds of criteria. Anybody have any questions about that? I'm sorry that we kind of got to a late start here. Do we have time to do another one, you think? Or are we running late, or you might stay in a few minutes? It's up to y'all.
I'd say we do it.
We have time.